Okay, hello, good evening, and hello to everyone here all over the world, actually. Good. It's Thursday, it's 9 o'clock in the evening in Germany. And as always, the last Thursday every month, we have here in the evening in Germany a nice webinar from our consultancy, that's Market Access and Pricing Strategy. And our topic tonight is the digital health in Germany. Is it start of a rocket or just a big bluff? So we are at Mars. We are consulting, German-speaking consultant, market access experts or consultancy, and we're covering the countries Austria, Germany, and Switzerland. And we support you there, everything with pricing and reimbursement strategies, health economics, reimbursement decisions, with all the paperwork, for example, with the Federal Joint Committee, with the digital health applications, the Swiss BAG or the Austrian HVV. And we, of course, support you with the negotiation support, including our virtual reality bootcamp. Just to make you brief here for the price negotiations, you will have with some authorities. Yes, and as always, feel free to ask questions after the presentation. We will have time for your questions, and you can either use the chat function here in Zoom to raise your questions, or we also open the question and answer tool at Zoom. So both ways will work. And the first question is, as always, do you provide the slides after that and the video? And of course, we provide you that. And for the video, also just go on our websites and check out all the webinars are here listed, especially like the last twos, and also like the really good one with our friends from Purple Squirrels Economics about the 2020 US elections. Okay, so if you have missed their webinar, check that out. Well, and now I'm happy to introduce tonight's speakers. It's Dr. Stefan Walzer, who is the CEO of Mars, and also our good colleague from the other side, from the State Health Insurances, Dr. Ulf Malweit, a prominent payer and expert on digital healthcare within the State Health Insurance system. Good evening, Dr. Malweit.
Thank you.
And now, Stefan, the floor is yours about that wonderful topic, about that big bluff. I mean, we have seen now already 10 digas. Digas started in the process last year in April, and now we already have 10. So it's really a rocket.
Let's just see. I think that was the idea. I think also when we put that together, I think we'll not only focus on digas. I think what we will really try to do today is we have picked out the different aspects, different laws, different regulations, which have as well just been introduced in the last couple of months. And we just want to understand if really this is really the start into the future, maybe, or whether it's really just, I mean, as we just put it into the topic, the big bluff. So let's just put a couple of those thoughts and maybe also information in there. And then I think I'm happy and open for a good discussion, and also obviously on the insights from you, Dr. Malweit, from your perspective. So let's just generally start. Obviously, there is the kind of right momentum for digitalization, right? I mean, not to say that I think especially the lawmakers in Germany, and I think I personally think it's also clearly the driver by the German health minister has already as well started even before the COVID-19 pandemic. But clearly, I think nowadays and currently, I think it is the right time in any way, not only in healthcare, but also in healthcare in order to boost, let's say, into that kind of direction. We have here as well the kind of differentiation that's also the important, obviously as well, always differentiation between the outpatient and the inpatient setting in Germany. And it is quite clear that we'll see that as well in the next couple of minutes. There is also a quite big boost, not only in the outpatient setting, but I think also in the inpatient setting for digital transformation. So not only that, I think, so we're not only seeing that, I think, just to start with, from a systems perspective, but it's also quite clear that the current situation also led to a shift, I think at least on a low level, but I think there might be a shift in the mindset of physicians. I think there's a greater willingness to use digital innovations. I think there are some numbers out there. I think that you have a doubling, for example, in the use and the openness of it, but I think still, I think on a quite low level. So maybe as well something where I think Dr. Maywald could maybe as well comment on towards the end of the presentation. But let's just maybe take as well a bit of a step backwards. Where does Germany really start at from a digital perspective in healthcare? So I think before really going into some of those different aspects and different kind of new initiatives or regulations, I think it's also important to understand the whole kind of situation in Germany, right? And we're still speaking and discussing about a bit more than 100 individual health insurance funds just in the statutory health insurance system, which is still, I think, 85, 90% of the overall market. But it is a huge number if you just consider the number of insured populations as well. And I think that's also one of the big differences, for example, when considering and discussing about the digitalizations in the last couple of months and years. It's not only the individual health insurance funds, clearly. I think at the end of the day, it's another kind of important consideration. We see that also, for example, in the way how the COVID-19 pandemic is being managed, but not only there, right? I mean, we have 17 associations of statutory health insurance physicians, the KVs, and also 16 Länders, regions in Germany, what you see also on the left-hand side in that, let's say, simplified map there, right? So we have a structure as well, a political structure in Germany, which is also not that easy, let's say, in order to do kind of top-down approach, also not from a digital perspective. We see that in healthcare, but we see it also in other areas. So also this one, I think, is an important consideration when speaking and discussing about, let's say, the moves and also the changes, I think, in such a system. On top of that, I've just mentioned that as well in the introduction, there's a strict separation, at least still currently on there, between the in and the outpatient setting, which is also from a budget perspective, sometimes it has its advantages, right? I mean, we see that and we know that from different reimbursement processes. But at the end of the day, I think, especially if there's maybe a limit in the integration, there might also be some kind of issues. And we have also seen that, and we see that still, I think, for example, with the electronic patient file, which is, I think, just being more or less, I think, introduced now in the last couple of weeks and also in the coming months. And finally, also keep in mind, we have a diverse hospital landscape, for example, if you briefly jump as well into the inpatient setting with private hospitals, big university hospitals, and also various smaller hospitals with different owners. So all in all, I think it is a real, I think, heterogeneous kind of system with heterogeneous kind of drivers and stakeholders, keeping that in mind also when considering and also, let's say, evaluating the kind of system also from a digital perspective. So status quo, digitalization in Germany. I mean, whoever knows me knows exactly that I like to do those jokes with the fax machines, right? I think it's probably one of the very few countries where fax machines are still being sold. I know, and I learned that also in Japan, in the US, and in a couple of other countries, also fax machines are still being used also by physicians in other areas as well. But I think it is a bit of a symbolic kind of thing, I think, as well, when you see those, let's say, machines still, for example, in physician offices. Anyhow, let's move that maybe a bit aside, let's say from a joking perspective, and just quickly having a look on the data. You see the references. If you need further information, just dig into it or just contact us, and we'll be happy to send you those as well. But just generally, the current level of adoption based on HIT, it's basically more kind of inpatient perspective here before we also jump a bit later on into the outpatient. But it's also quite clearly shown that just 60% of the German hospitals are just above the first stage of such a scale. So the first stage is really at the bottom and just one step up. So 60% of those still are at a very low level. I think 36% have fully introduced internal Wi-Fi, which I think sometimes is also a bit strange to me when especially I, for example, discuss that with clients or just go around with clients as well to different hospitals. And finally, we have around 11% fully implemented the EHR systems across Germany. So overall, even that we can say, I think they are also good good examples, good kind of hospitals which have as well been already on the forefront. But I think on average, I think we're probably more on the lower end of that scale. The same basically if you take some other as well references in the ranking of hurdles for digitalization, also clearly shows the reasons for it is lack of funding. That was at least before. I think we have also seen some of those new regulations, sometimes also the missing qualified IT personnel, which is probably more the question how to attract those people as well to work, let's say, in the healthcare system. I think also that one is probably more kind of incentive kind of question, and also obviously a bit of scarcity kind of issue. And finally, I think that was an interesting one, interpretability of the IT systems when we have had a look on that. So finally, I think still there are now several initiatives, especially from a national perspective, but I will also show you in a second a potential regional one, which target on the digital transformation in the healthcare system. So the key issues, I think we have just said that, especially funding, but also personal. But you see also on the right-hand side, a couple of other reasons which you can also pick out there, which is sometimes a bit of an issue. For example, the missing kind of interconnectivity between the different kind of also external stakeholders, which is sometimes a bit seen as an issue. So let's just move away from the status quo where we start. So let's just directly go into the implementation. How is digital healthcare now being implemented in Germany? You see already with the question, I think I see it more positively, I think, especially when having a look on the last, I guess, 2 or 3 years. So just start with it, right? Starting here again, also we try to do still that separation, even that I think an integration is much more as well a part of the future, which might also come. I think there are also different projects currently going on. But let's start with the inpatient setting. Funding of digitalization in German hospitals could also be, let's say, differentiated between different levels, right? I mean, there's a macro level, a meso level, and a micro level. And within all of those, there might be different paths for how and in which ways digitalization could be funded in German hospitals. That's a Hospital Future Act. We have a slide on that in a couple of minutes. There might also be, we put it in brackets, the Innovation Fund. I think the Innovation Fund is also already, let's say, up and running, and also with quite big investments, I think, with big money as well behind since a couple of years and still ongoing. So I think also there's also some opportunities potentially for those kind of digitalization projects, and also obviously additional necessary money for investments, which is as well available. On the meso level, there might be individual states which are then responsible for the funding of the investment in hospitals. I think that's their kind of as well requirement. I mean, we see that as well in a couple of minutes with one example where and how, let's say, those kind of digitalization efforts could potentially also be supported also from a political perspective, but it's also quite clear. I mean, just remember, we have 16 different regions, states in Germany, so that might also be a bit of a different kind of angle here. And finally, also linked to what I said earlier, on a micro level, hospitals' own budget could also be, and is still, I think, at least as far as we have had a discussion on, I think that was late autumn where we had as well some kind of research on that, is still the most common way of funding currently in terms of digitalization, but I think also in general in German hospitals. And I think that's also quite clear. Keep in mind that we also have private chains in hospitals, and that's clearly an advantage for those chains. So the Hospital Future Act, I think at the end of the day, you would probably just simply need to read, I think from my perspective, the very first bullet here and the very last one, which I think shows as well the kind of two different angles where that act is basically really trying to push for digitalization, right? One is the monetary incentive, but I think secondly is also, let's say, penalties for hospitals who are not reaching at least a minimum of a digitalization infrastructure by 2025, to start with the very last bullet here. So that's something maybe as well keep in mind. There are a lot of different kind of specifics on that. We'll not touch base on those, but I think just in general, I think it shows that there's overall 3 billion euros available for digitalization project in hospitals, that different requirements, different items you need to fulfill. It's not just an easy run and just say, you know what, I want to have a new robot or whatever. It's a clear kind of, let's say, pathway behind that. And I don't know, maybe if Maywald also wants to quickly jump on that, but maybe we'll also shift that maybe to another kind of discussion in the near future. Important is quite clearly, there is an incentive on the one hand side, but there's also kind of clear penalty, so a push that also hospitals might as well move into that kind of direction by 2025 because of potential budget cuts if they don't fulfill those minimum infrastructure means. Another example is also, I think, what I mentioned some minutes ago. Just keep in mind the Länder, the region, the states are responsible for the funding of investment, generally for investments in hospitals and its infrastructure. And I mean, there is a, let's say, kind of a, I personally think it's a quite prominent example. I mean, I'm living in the southwest region, which is just highlighted here on the left-hand map. It's called Baden-Württemberg. And I mean, what we have seen also from the health ministry there is a quite clear push towards funding programs, which are also linked to some specifications. So sometimes it is also more that I think that was especially before the pandemic, obviously, that Baden-Württemberg and the ministry there was especially more focusing on the funding on hospital mergers. So it was not so much to bring, let's say, a different kind of hospital from different regions together, so just that we have an administrative kind of merger, but it was more the kind of idea that sometimes we had different, let's say, hospitals in a city or in a close kind of environment, that there was just more the kind of push, let's have a new kind of also building and hence infrastructure being built, and that was then also linked to further funding. So besides and beyond what is maybe and was maybe then as well needed for those kind of investments, which I think sometimes made a lot of sense. I mean, we have also seen that just here around the corner. And sometimes, obviously, there were some more debates, which I think was also quite interesting to be followed in the regional kind of press. But it also shows that I think also the regions and also the states have some flexibilities, for example, to push as well the healthcare environment in a given kind of direction. That is why I just thought we bring that as well into that kind of perspective. So moving a bit away now from the examples in the inpatient setting here. In the outpatient setting, I think we could also just see it, I think, a bit positively sometimes, right? I think at least the first ones we have just seen in terms of a code available for the outpatient setting was already introduced in 2016, which I think is quite a while ago now, which it was also on the monitoring of patients with a defibrillator or CRT system, which was quite interesting. I think that was clearly before the COVID-19 outbreak, and I think whoever was also following us last year, I mean, we have also shown already that there were also some new codes being implemented during the pandemic, which was especially more on the telemedical kind of applications, the teleconsultations, also video consultations, which have also been, I think, a bit changed here and there. I think also in terms of number of usages, et cetera, over time, in order to also push there in the outpatient setting. I'm not covering at this stage now on that slide the digas, but obviously also those will have, and I'll show that as well in a second, a potential impact on the updates and new kind of EBM codes in the near future, I think. So finally, I think after the hospital settings and with the different kind of potential regulations, where I think there might be a big push, and we have not mentioned here the electronic patient file here. I think that's maybe as well something maybe interesting to cover, Dr. Maywald, in a second, just to see obviously how the kind of movement and how the kind of implementation worked on that side. But I think it's also quite clear because it also has been seen as well in various international presses or in different newspapers, different scientific papers, journals, but also, for example, in the Harvard Business Review, which have all basically taken up the kind of implementation of the so-called diga pathway, right, which has also the kind of impact for digital health innovations. So let's also spend some minutes on that aspect. Lutz has also mentioned it. I think, what is a diga? I think it's not just the most easy thing. I think it's not just an app on a mobile, on a smartphone, which sometimes is just being seen. I think the translation of the terminology, I think, is sometimes a bit misleading, to be honest. I think if we're speaking about eine Gesundheitsanwendung, eine Anwendung is not just simply an app per se. So we have as well just included there the definition. I will not go really into details here on all of those aspects, but I think it's very important here as well that it needs to support the insured person or in mainly outpatient care by the service provider. So it's not just another monitoring tool, for example, for the physicians. I think that is then sometimes a bit the difficulty as well from both sides, right? To understand and also to explain those kind of differences. But that's, I think, one of the main points to understand besides those other kind of definitions, which I think are also available in English language on the BfArM side. So which types of diga listings are available? I'm just bringing those as well up because we have the list just to see in which ones were as well accepted in the last couple of months. There's obviously a permanent registration, which means the diga is directly listed and permanently included. Also then after the price negotiation in terms of regular reimbursement. And there's then also the preliminary registration. I'm just mentioning that as well, obviously, because you can then also, let's say, use the time when still already on the market and also being reimbursed in order to create and develop some of the evidence. I think also here maybe an interesting discussion here in which ways this should really then being applied as we see it from the AMNOG process versus the information, the evidence sometimes also available in the diga environment. So very briefly as well here, we have had a special diga webinar last year, but also it's quite clear to understand there are different stakeholders here as well. And we have the BfArM, which is basically dealing with those digas. They are checking the application. They should check it as well within 3 months, meaning 3 months after the full application being available. So if there might be missing information, something unclear or something like that, then the BfArM is also going back and discussing or requesting those kind of information from the submitting company. And hence those 3 months could be also longer. I think that might also be maybe an explanation when we see the number of submissions and they're currently already available and positively decided digas within that kind of time frame. I mean, if the BfArM then decides that the diga is not only diga, but can as well be included, for example, on the preliminary registrations perspective, I have left the permanent out because it's very similar to it, but just that they obviously decide based on the evidence submitted, then on a permanent inclusion, then the diga might be included in the so-called diga registry, and the journey could basically go on, including obviously the development of the sufficient evidence, right? So what that might be, I think we have a sign there as well with the BfArM, would we look for when we quickly present as well the different kind of available digas. So time to reimbursement, that's maybe also obviously always a question. You see just here on the top level here, there's the application for the inclusion of the diga directory, then the BfArM decides within 3 months, and then there is basically 12 months free pricing as well available where the diga is being available and could be used as well by the patient and also being prescribed for. And I think when that price is then being negotiated, I think is currently still under a discussion also within the kind of price frame where I think there's still not an agreed kind of framework currently, but it looks at least for the permanently one, there might even be a further kind of follow-up, I think, beyond that 12 months, as far as I understand, which is, I think, also core difference maybe to the AMNOG process. Let's just see. And I think important here as well, maybe more on the bottom of that slide, where it says EBM adjustment within 3 months for medical services associated with the diga. I think that's also something what I tried to mention a couple of slides before when we spoke about the outpatient coding. And that also means that I think we will see some adjustments also over time within that EBM outpatient coding, as we might also see more digas, and hence we might also see there maybe some more needs for one or the other new code, especially maybe for the explanation, for the kind of support of the patient with the diga, etc. So are those digas really successful? I think I'm nearly through, so we can as well jump into the discussion. But I think very quickly, those, let's say, graphs are also from the BfArM website. There were 53 applications since last late spring. 35 of those applications were for the preliminary registration within the BfArM registry. 18 were for the permanent registration. And what you see then also when you jump from the left-hand side to the right-hand side, 10 of those digas have been approved. So 10 are already in the registry included. One was rejected and 18 were basically withdrawn. So currently there are still 24 more in the kind of evaluation by the BfArM. How that would we look for, how this is really being or should be also interpreted is maybe still an open discussion. I mean, I have my opinion, I can share that maybe as well later on, but let's just see. I mean, I think it's also a bit of a question, I think, which of those digas have been successful. I think to me, I think it's not so much that you check, I mean, which of those, let's say, digas are where available or whatever, but I think really important is maybe more, maybe check first of all the kind of columns on the inclusion and the evidence. So just on that slide, I mean, this is just half of it, right? We have the rest, the others on the next slide, but the permanent inclusion has had an RCT in Germany, that is Elevida, just on the very first row. So that just basically met the permanent inclusion. Then we have a couple of those with the preliminary inclusion. Also here important, just when you go through it, you see RCT planned, German study planned, German RCT planned, and again, a study planned. But I think in all of those, I think it's also quite clear to me, at least what we have seen so far, that probably it will and should be, I think, randomized controlled trial. It is consistent also with the other digas which are available. Just check who made it to the permanent inclusion, only the ones who had an RCT in where at least Germany was also included in the country basket, and the others with the preliminary inclusion have had maybe the kind of question on which kind of study to run. I think besides maybe Vivira, where we also only can see retrospective study, I think it was quite clearly also mentioned in all of the communication we have been seeing that there isn't a randomized controlled trial being planned. That's maybe as well, maybe a bit of a kind of learning. I think there was some discussions also, I think beginning of last year, if really RCTs are needed for digas, or maybe if, for example, kind of registry data or one arm kind of data, it could also be sufficient for the BfArM. I think, yes, sample size n equals 10 is maybe still on a small size, but I think the discussions, I think we have as well personally seen, and also what you see here from the accepted kind of digas, I think at least shows a clear kind of trend towards an RCT. I think maybe also, I think what I would as well like to understand maybe a bit, I think with my red, when we also could check quickly your opinion on the prices. I know that there is an official kind of statement being done by the Institute, by the head association of the Institute of Health Insurance Funds, that they think that the prices are clearly on the upper end, to name it maybe positively, and quite clearly the industry sees that from the other perspective. Just maybe also have a quick look here. I think there is the Elevida with roughly 700 euros cross for a prescription period of 90 days. Then you have a quite huge variation, let's say, with somewhere around 100 euros for 90 days, and everything somewhere between 200, 400, 500 euros for a prescription period of 90 days. We don't have a price anchor here. We don't have done the evaluation yet, but I think there are at least different opinions, different as well directions, and also how that could basically be interpreted. So having said that, I think I tried to do a kind of, let's say, summary of, I think, the last couple of months. I think there were many more, I think, initiatives as well happening still on the national, but especially obviously also on regional level. But I would just like to invite Ulf Maywald from the AOK Saxonia to maybe as well jump in there and maybe just start generally, right? I mean, we said it as well in the title of the webinar. Is it now rocket or is it a bluff? What is your perspective on that?
Yeah, thank you. I think it's currently it's neither nor, to be honest. We are at the starting point of a very long way in Germany. as well as at the physician side, to take them with us on that way to digitalization. The sickness funds, the principle of subsidiarity, the German Bundesländer, and all of them, or for all of them, this process is completely new. And the current Minister of Health is very active. Someone might say hyperactive. So he made 3 digitalization laws in one legislation period within 4 years. And even before the first law came into effect, the second was on its way. And now the whole system is busy on sorting those regulations and finding what to do next, let's say. But I think anyone accepts that the way is necessary to go down that way, but we have different speeds at the different stakeholders in the German system. And one stakeholder which is important to go that way, unfortunately, has the slowest speed is the outpatient doctor. And so we have a couple of problems. I will come to that. Maybe you asked me to start a bit more general, and then I will go to digas. I think one word to this electronic medical records. Since January 1st this year, so since 28 days now, the sickness funds are obliged by law to offer an electronic medical record to all of their insurees. We made that, but the first stage, let's say beta version, even fits the law, is now available, and it's, to be honest, it's a hyper secure, bit autistic Dropbox. Yeah, the patient can upload a file with its mobile device and its EMR front end, but we have no hospital and no physician who can download anything, because the software systems of the doctors and of the hospitals are not as quick as the sickness funds had to be quick due to that law. And now we try to fit those pieces of puzzle into each other. I think in 1 year from now on, we will have the first productive stage, which brings effects into the processes of providing care of such an electronic medical record. Currently, we have just started, let's say, but in future, this will be a much more central piece of truth, let's say, for all the hospitals and doctors who are taking care for a certain physician. But this will need between 2 and 5 years from now on, for sure. Same a bit with video consultations. We had a slide on those video consultations and a question in the chat here to give you a number. I think video consultations got a quite uptake due to the COVID crisis, because the doctors' offices were closed for, especially in spring this year, and the video consultation software manufacturers offered their video consultation solutions up to the end of December last year for free. Yeah, and so the number of doctors who offered video consultations increased by 400%. Up to December 2020. And now, yesterday I had a call with one big manufacturer of those guys. It stepped back to the number of January last year, because now there's a subscription period has begun in January 21. Yeah, it was only for free until December. And 75% of the doctors thought, okay, it's not that important if I have to pay 50 euros per month to earn a multiple of them with video consultations. And that's the mind of the current German doctor, and will also need time, let's say. And I think it's the patients have to actively request such things from themselves. The doctors won't offer it. But with the new generation of patients, which are more digital natives, this will change by time, but not really quickly. And a few words to the digas. It was included into the German law in March 2020, I think. Then the B firm had to set up its processes, and Mr. Walzer said it's a very good website at the B firm where you can see that process and the assessment criterions. And the first assessments ended in October. So we had in October last year the first listings of digas. During that time, we had to build a process for reimbursement those things, because in Germany there is no reimbursement directly to the, let's say the patient has no upfront payment and gets nothing back from the sickness fund. The sickness fund has a direct financial relationship with the diga manufacturer. And we had to set up APIs and processes for that. And so since October it works, but my sickness fund insures 3.5 million patients. And we have from October until end of January, we have 110 diga prescriptions. Right? So it's not that much, to be honest. And this has a lot of reasons. Yes, the process is not yet stable. The diga manufacturers are not really professionalized. We have a lot of startups there, not a classical pharmaceutical manufacturer with processes, with field force, with all that stuff. And the main problem, I think, is the doctors are reluctant. They currently do not have enough information on those digas, maybe because there is no field force. They have doubts on medical benefit, especially for those which are only preliminary listed with retrospective studies. There is a big fear of the doctor of becoming the first level technical supporter for the patient. Yeah? And the doctor wants to treat the patient, but doesn't want to be the technical supporter if he has a problem on his smartphone with the diga. And they are feeling, I think, that the prices are not really adequate. The German lawgiver and our auditorium, which is familiar with the AMNOG process, might have noticed it, took the AMNOG process as an example, and now you have free pricing for digas in year one, the benefit assessment, and then a price negotiation. And the sickness fund is more at the, or has more the perspective to say, okay, a digital app is never as urgent as an end-stage cancer therapy. Yeah? And free pricing maybe is a bad idea, so negotiate first and then reimburse would be better. And that's also a bit the perspective of the doctor. And if they do see a diga with 750 euro per 3 months, this means 3,000 euro per year. To answer also that question in the chat, it can be repeated this period if the doctor fills a new prescription. Then you have 3K yearly therapy costs for an app, which is undoubtedly preliminary listed. And you have not that much drugs with those costs, to be honest. Especially in the CV sector, so the things are much cheaper, and the doctor makes such relationships in its mind and becomes reluctant to prescribe. So there are pros, there are cons for sure. Pros are, even the sickness funds do see there is a chance of saving costs and improving care. If I look to the ESCO Congress last year, there was an adherence app for NSCLC patients with an RCT and shown improving overall survival with this app. That's good, and for that we would be happy to pay money. And for other things with a retrospective study, preliminary listing, might be they will conduct an RCT, might be not. No one feels really well while it's paying such a thing. And so depends, let's say. And the cons, I think I already mentioned, to less information to the doctor. Currently, the apps are not really included in the process of providing care for the doctor. They are feeling a bit like a foreign particle. It needs time. They need to monitor an additional feedback channel. The question is, how does the feedback of the patient self-tracked data comes to the doctor, and how can he include it into its decisions and into its process of providing care? And we have a lot of open questions. We are working on those questions, but it's the same as for the electronic medical health records. In 2 to 3 years from now on, I think we will have some kind of culture for digas. We will have solved this feedback channel problem. But we are also at the starting point of that long journey, let's say.
Yes,
maybe so much, and then we can open the discussion.
Yeah, no, thank you. First of all, I think I think you have already, I think, more or less as well taken up the kind of conclusions what we, I think, also thought when we put the different slides together. I think digitalization has, I think, probably strongly picked up, probably more from the, I think, German healthcare lawmakers maybe as well. I think probably not so much from the system yet. But I mean, as you exactly said, I think I can only agree. I think if it will be a success story, it would still need to be proven. I think there are good signs. I think there are good initiatives. I think there are good starting points. But I agree. I think especially also with the point you have just raised, I think it is a heterogeneous kind of system, not only from the health insurance and from the different other stakeholders, but I think also from the physician's perspective, for example, not to forget, obviously, the very heterogeneous patients, right? I mean, we have those 80 years old patients versus those 16 or 25 years old patients. I think it's a huge kind of difference. And I fully agree. I think we also all probably first need to find the right pathway into that kind of future field. I think, yeah, Lutz, back to you as a kind of moderator with or to some of the questions we might have already as well received from the audience.
Yeah, actually, we have quite a good range of questions. Thank you, Dr. Ulf Marwald, and thank you, Stefan, for this wonderful presentation and your insights here in that digital topic. So the question the audience raised are like divided into two parts. The one is about that different states and the digitalizations in the hospitals, and the other one is about the digas. So we were just at the digas, so let's start first. So there was one question about what the DACH region is. So DACH means for Germany, Austria, and Switzerland. That's that. Then there's another question about the maximum price paid. I mean, Ulf Marwald already were talking about that. So there's idea in the law, let's talk about, or let's formulate it that way, that there's like a maximum range for the digas, and there are negotiations between the head association of the state health insurances and the manufacturers associations. And but as Ulf Marwald, do you know more about that? But as I know,
formally, there is no maximum price. Yeah? You have free pricing in year one. The question is, do you find a doctor who is insane enough to make a prescription?
Yeah, exactly.
2,000 euro per 90 days period or something like that.
Yeah.
But if you need that price for the gallery, and if you can live with no prescriptions, you can take any price you want. And then within those 12 months, you will have the negotiation, or at the end, maybe the arbitration. It's quite the same like the MNOC process. And as we have no experiences with that process, I think to get a price from more than 1,000 euro per 90 days period, you have to provide something like overall survival improvement in an RCT. Yeah. But not a retrospective study or only a bit process optimization or something like that.
Yeah, I think that's probably the most important thing here. I think would you also I think just summarize it. I think that's also, I think, what is currently being discussed between and also within different kind of let's say stakeholders. I think the question is always the kind of, let's say, differentiation between the kind of evidence what you have and then the price you want to charge within that free pricing period. And I think that's a bit of the kind of tricky and shaky kind of environment currently, I think. And also, I mean, you also brought up the kind of point, what if there's no real evidence and still there might be 300, 400, 500 euros per 90 days. I think that's maybe the bit of the discussion. If it might suddenly, let's say, prove the evidence, it's still the kind of question. I mean, you have just seen that on that list as well. I think the different, let's say, indications, right? I mean, if we're speaking about, let's say, an overall survival benefit of another 3-6 months in a lung cancer or in a breast cancer indication, or whether we have maybe an improvement in a pain scale of maybe, I don't know, 10%, which could also be an important one, right? But I think there might be as well differences, I think, and that's, I think, also what you, I think, we've just put up there.
Then there's another interesting question: is there any information on the willingness to pay some additional contribution for digital health by the patients? So the patients can, like, can contribute some money by themselves. That by law, that's just not foreseen. So everything is covered by
let's say within a single diga which is listed at the B firm and which is part of this principle of benefits in kind and is directly paid by the sickness fund. There is even no co-payment for in-ad by in-ad Kauf. Don't know what is in English.
Yeah.
in
additional payment or in the ad payment. purchase.
In-app payments are not foreseen.
Yeah.
It's binary. Either everything is paid by the sickness funds or nothing is paid by the sickness funds for those listed digas. There is a lot of digital health apps which does not fulfill the BFARM criterion, nevertheless available in the App Store. And there are patients who are buying those things, but in general, I think the average German patient has some kind of full service mentality and thinks if the system does not pay for, it's not worth to pay at all for it. So it's yes, it exists, but it's limited.
Yeah, and maybe just to add to that, and maybe you can as well remember, I think it's probably already, I don't know, 15 years, 16 years ago, I think, when there was the kind of decision also by the Statutory Health Insurance Fund to limit, I think it was in the diabetes area, the kind of, I think it was a given drug, as far as I remember, I think it was a Pfizer drug to maximum amount. And I think still Pfizer wanted to charge some additional, let's say, price, and just wanted to have the patient to pay that on their own. And I think they just tried it, I think it was 4 or 5 months, and it didn't really work out. So I agree. I think would you have it just as well just said, I think there is a kind of mentality that that all German patients have the rights to get everything basically for free. And I think that's a bit the kind of tricky part if you especially want to enter the healthcare system, versus I think if you have obviously something like a kind of, let's say, simple app in a way, which you sell for a couple of few euros in the App Store, that's obviously, I think, a different world.
Yeah, I think a diabetes diary for 10 euro one time in the App Store, every diabetician is willing to buy, but paying 200 euros a month for a certain app, no way. Yeah.
Okay. Then there's a question if there's an app and also a hardware with a supportive hardware, is that possible, or can be the hardware in the middle with a supportive app? No, the digital app has to be in the middle, has to be the center of the technology. That's a question I already answered. Then there are some examples, ask for some examples on a macro, meso, and micro level. For the solutions, we showed the 10 digital apps that were already there listed at the BFARM. And then, Stefan, do we have on the list that if it's medical devices 1 or 2B? No, we did not listed that on that slides, right?
Yeah, I mean, a diga is only, I think, or let's say the definition of diga only includes class 1 and class 2A, right? I mean, I don't have the information on the slide for that differentiation, but that's easy enough, I think, available. I think it should also be even available on the BFARM website. I think if you just click on the individual digas which are available there, I think you can easily just find it out.
Okay, and then there's a question you just raised, the diabetes diary. What is the general view in Germany about the reimbursement of lifestyle treatment for diabetes type 2 patients, online and offline treatment?
No, I'm not sure if I do understand this correct, this question. If there is, I can imagine digas for, let's say, changing lifestyle and changing behavior. We have digas showing in that direction. And if that diga fulfills the BFARM criteria for listing, it's reimbursed as a normal diga, as all the others we have seen in those slides. There is no special pathway for diabetes or something like that. And if it's combined online and offline, it depends what it means. Offline, is it a drug? Is it a psychotherapy? So I would need a bit more information on that question. But in general, digas for changing lifestyle are imaginable, but again, it has to be proven that they are really successful and the patient uses them and gets the results.
Okay, offline is physical meetings with patients. Yes, I think that is like more likely the case here in Germany with the diabetes type 2 patients. I mean,
yeah, we do have a disease management program for diabetes type 2 with specialized diabetes nurses, and those offline consultations are already occurring, let's say. And the question is, can they be enriched by a diabetes diga on a patient can do
in
at
a
home.
good way. Okay, let's switch to the hospitals and the competition and the digital center there. I mean, there's a lot of discussions about the states, the different regions, and they administer the investment. So the state government, they are responsible for the funding for the hospital. And the question, if so, on what basis does the German government determine its fundings allocations to the different lender or to the different states? Stefan, could you go elaborate a little bit more on that? What happens if one region is more successful than another region in its digitalization initiatives?
I think you can probably fill courses with that. I think when I was in university, I think I need to study that for probably 2 semesters. I think it's a whole kind of financing, right? I think and not only of the healthcare system, but I think in general, I think the federal system really works. I think in Germany, I think we could maybe take that up, and I can send maybe. I think there are a few, I think, good explanatory kind of articles available. I think even in English, which we can also share afterwards. I think would probably be too much for a short kind of answer within that webinar.
Yeah, my short answer would be the prime minister of this federal state can grow a bit more across the other prime ministers. Yeah? But that's the only consequence.
Probably they say, look, we're so bad, we need more money. And suddenly there's the next program actually is coming out. I mean, there was this program where there was where they really pushed money in there and still only like the good hospitals were or some hospitals were really investing in that. There was these 11%, right? And the others did not. And then now the next round is coming to support the money with the money.
The problem is often this money is for cost of goods, not for personnel. Yeah? And the bigger hospitals have a better starting point. They have at least an IT department or something like that, which can use new money for hardware and for whatever. And a smaller hospital gets not funded personnel costs, gets funded hardware costs, but cannot use it as they have no qualified guys there to make it true.
Yeah, that's correct. Especially these qualified guys are really, really expensive, right? So that is also about the salary, and the hospitals, they're within their also given regulations. Sometimes it's hard for them to pay that what the IT guys would get in normal businesses. Okay. There's another question. We had also selective contracts in one webinar, so check that out. And the question is, has a diga regulation replaced selective contracts with individual sick funds, or they are still possible?
Both is possible.
Both is still possible. Yeah. Do you know any examples where it's a selective contract is now replaced with a diga?
No, it's a business decision of the diga manufacturer which way to go, let's say, because this diga way is also a bit risky. If you fail to be listed at the B farm, you have that stamp useless. Yeah? And maybe no one wants to make selective contracts with you after that if you fail in that process. And so some manufacturers actively decided to still go only for individual contracts with sickness funds. And both is currently possible. In theory, you have with the diga pathway the broader market access. If the physician would be informed and would prescribe the things, it's independent of the individual sickness funds. In this selective contract, only the insurer of the individual sickness fund can get that app, but both works. And to tell you that anecdote, we do have digas which were in selective contracts and then decided to switch to that diga way. And what wonder, the price was, after starting as a diga, tenfold the price in the selective contract, because it was free pricing for year one.
Looking forward to that price negotiation.
Yeah. Well, there's one question. If there's
I see climate during that negotiation.
Yeah, you get really ice cold hello from the other side. Yeah. there's a question, are there any pricing negotiation on digas already going on, and what rebates are likely expected? Well, the price negotiations are like all confidential, so there will be like no announcement that something is going on, and no, we don't have
currently
any.
there was not even one price negotiation, because at first the diga manufacturers and the Federal Association of Sick Funds has to agree on a framework contract for those pricing negotiations, same as for AMNOG. And this is again highly conflictive, this framework contract, and the framework contract is currently going to the arbitration board. So my best guess is we will have in March or April a framework for that pricing negotiations, and then the first negotiations from
and we have we have 12 months, right, to negotiate. So this is also like a bigger time frame to negotiate.
Yeah, 12 months time.
So when until October, it's a long time.
They are still on time, even if they go to arbitration with that framework contract.
Yeah, exactly. Okay, there's one last question about the early adopters incentive programs for some physicians. There's something that also for the physicians are support by the German government? Any program?
No, the physician has cost of goods, and if he does invest something in a better digital practice, he gets more patients and can earn more money, but it's its own problem. For physicians, there is no specific program to support digitalization. Yes, there is something, so the government pays, I think, 10 euros for the first upload in the electronic medical health record and such small things. Yeah, a bit more honorarium for doing something with the digital possibilities. But setting up the digital possibilities in the own practice, it's cost of goods of the physician. Yeah.
Okay, thank you, Dr. Maywald. So it's almost 10 o'clock. We close now the discussion for tonight. There's some questions left. We try to answer that now on the Zoom account. And then also, if you have any questions left, shoot Stefan an email, and also check out our webpage with the recording of the webinar. Okay, and then we want to present you actually our next webinar, which is actually in a month on February 25th. And then we will have a discussion with our good friend Remo Christen. He's from Roche in Switzerland, and we are talking about the Swiss environment, the Alps, cheese and banks, and the early paid access for drugs. It's is Switzerland a wonderland? Yes or no? And feel free to register here for our next webinar on Zoom. In the next days, we will bring that up. So thank you again, Stefan, for this wonderful presentation, and Dr. Ulf Maywald for these great insights here and your opinion on the current environment. Well, we learned it's neither a bluff nor a rocket. So we hope that it's at least, there's still like Fly Germany, fly a little bit on the digitalization eagle way, and we have some digital success here. And we get some. Sometimes, I mean, the German parliament decided now in the next period to get rid of the fax machines, so we will hope that this will also happen with the physicians. I mean, there's also like the big try at the local health agencies here dealing with the COVID situation. Then they get more regional because all the fax machines are broken up now with all the COVID situation. Okay, anyhow, have a wonderful evening or day, and stay healthy, and have a good digital health also. And goodbye and good luck.
Thank you. Thank you for the insights. Thank you. See you soon.
Bye.